Hi there, this is Integrative Therapies for the Intervention of Migraines. I'm Tom Smith and I'm going to be your instructor today. I did want to go ahead and give you a little background to let you know who I am and what it is I do. I have my master's degree in psychology. I'm a licensed mental health counselor. I'm a nationally certified psychologist, as well as being a fellow of the American Psychotherapy Association. I'm a board-certified clinical psychotherapist, but I also have my bachelor's degree in pharmacy. I'm a doctor of pharmacy and a fellow of the American Society of Consultant Pharmacists. When I talk about migraines, it's an intriguing topic. I did want to go ahead and make sure that you knew what we're talking about. First off, I'd like to give you a quote. This is from Michel de Montaigne, and it says, "Fear of this illness used to terrify you. That was when it was unknown to you. The screams and distress of those who make the pain more acute by their unwillingness to bear it engender a horror of it in you." Now, I did want to discuss the concept of migraine headaches from a different standpoint. If you ask people, what's a migraine headache, they're going to have a tendency to describe either a personal experience or an experience of their own knowledge. Notably something along the lines of what my husband had or what my sister had. But I'm going to be talking about the pathophysiology and clinical presentation of migraines. That's a different way of looking at this odd condition. Let's start with, what is a migraine? One usually thinks of pain when thinking of migraines, but there is a physical element most frequently that is causing the headache, the pain, etc. There's no doubt that there are multiple systems that a patient would be experiencing that are physical. I don't deny that. However, one might also state that having a migraine is an emotional experience, or a spiritual one, or even a metaphysical one. For this section of the presentation, let's look at some of the physical characteristics, beginning with the down and dirty scientific stuff. I want to give you a case history of a 19-year-old woman who shows up in an emergency room with a chief complaint of headaches. See if this sounds vaguely familiar. She has had headaches for approximately 5 years, and they've been progressively increasing in frequency. She experiences a daily headache that she rates as 5 out of 10 in severity, and a severe one occurring once a week. More on her physical presentation, though. These severe headaches are accompanied by nausea, something called photophobia. She's afraid of light, or would actually shrink from a light source, as well as having an increase in pain in her head whenever she does move. She's worried because the daily headaches are located in a certain area of her brain called the occipital region, right behind the eye. But the severe headaches typically occur all through the occipital area. She was started on some medications by a physician's assistant in the emergency department when she showed up. And this is a drug called Depakine. It's pretty commonly used, believe it or not, for seizures. And we'll get into the concept of why you'd use a seizure medication for headaches as this presentation continues. But more on this patient. Besides taking that product called Depakote, she was also taking Cymbalta, which is an antidepressant, as well as Ritalin, which of all things is used for such things as attention deficit hyperactivity disorder. Additionally, she was taking such things as non-steroidal anti-inflammatory agents. Now, this is a pharmacy term. You've heard of it as Motrin or Advil, something along those lines. Her family history reveals that both patients experienced headaches, and she doesn't use alcohol or tobacco, but she does consume approximately 6 cans of caffeinated cola per day. When she shows up, she doesn't appear to be in acute distress in the emergency room. Her vital signs are pretty normal. Her blood pressure is 110/60. Her pulse rate is even 88 beats per minute, so she's doing okay. Respiratory rate, she's not going There's no fever. She has normal mental status and intact cranial nerves, so she's not appearing to be confused or having delusions. Her strength is 5 out of 5. That would be bilaterally. Have her squeeze her arms and her legs. In both upper and normal extremities, she's got normal bulk and tone. Deep tendon reflexes, when the doctor smacks you with a little hammer on your kneecap, they're 2+, and she's symmetric in all 4 extremities. Now, the reason I go through all this, I want you to see that this client specifically did not have anything going on in a way of a disease state like a tumor. We're trying to rule out tumors in this situation. The rest of her body, everything seemed to be fine. She was sensitive to pinprick. If you pricked her with a pin, ow! Temperature seemed to be fine. She could actually feel vibrations. She could even feel other pain stimuli like pinches and things like that. And when she walked, you didn't see anything fancy. Lab tests, nothing going on there. It showed that indeed her thyroid was working fine. She didn't have any blood coagulation problems. Everything seemed to be exactly as it should be. What was her diagnosis? Migraine without aura. And this is what I wanted you to understand, because migraine affects about 12% of the population. Folks, that's a ton of people. It really is. And often goes unrecognized and untreated. Many patients actually miss more leisure activities than work activities because of the nature of each attack. And I want to give you a couple of the several scientific diagnoses, just to give you an idea. There are different kinds of migraines, and the way we split them apart is specifically by their diagnostic criteria. Don't get hung up on this. I just want you to see that there are different kinds. If she has migraine without aura, that would be at least 5 attacks. 2 attacks for migraine with aura. And we'll get into the aura thing too. That would be fulfilling the following criteria. The headache attacks last from between 4 and 72 hours when untreated or unsuccessfully treated. The headache is accompanied by at least 2 of the following. That would be unilateral location, 1 point only. It's not all over the head. A pulsating quality. Also, it's aggravated by or causing avoidance of routine physical activity. So if she said, I'm going to go ahead and work through it, it's going to get worse. Or she's going to say, man, I just need to go ahead and lay down. It's one of those things, she's going to avoid her normal routine. But you can have moderate or severe pain intensity. Continuing with those diagnostic criteria, during the headache, at least one of the following occurs. Either she has nausea and or vomiting. Photophobia, which I'd mentioned just a little bit ago, that's where she actually appears to be afraid of the light. It's not a true phobia. It's just like, oh, turn the light off. Okay, let me go into a dark room. Also, phonophobia, which would be people are very sensitive to sounds. I've had some of my migraine clients who had phonophobia, who literally would complain about the ticking of a clock. You may remember years ago we had those Big Ben clocks, those wind-up things, and it tick, tick, tick. It was an alarm clock. But they're so profoundly sensitive, even the ticking of a clock makes them their headache get worse. By the same token, whenever you're talking about these diagnostic criteria, they're not attributed to anything other disorder, like, for instance, a tumor and things like that. Many patients will have a probable migraine, which is the above list that I just went through, minus 1 of the previous list. Okay, so they don't have to have all of them. If they have most of them, it's a probable migraine. Now, as you can see, it's easy to label this migraine as being a physical malady, and this returns to the question about the experience of a migraine as being so much more involved than meeting diagnostic criteria. Hang with me here, though. Let's forge ahead. More on the physical stuff. Originally, migraine was thought to be a vascular disorder based upon some experiments, no kidding, in the 1940s and 50s. From people who had migraine with aura. Now that's a very specific type of migraine. We'll get into that as the presentation continues. But there's a phenomenon that's called cortical spreading depression, CSD. Now this is really important. It's not a depression like I'm depressed. This has to do specifically a wave of increased blood flow, which precedes decreased blood flow into the brain. Okay? You do need to know that this can occur in migraine with aura as well as migraine without aura. But multiple recent studies have actually suggested that the migraine is generated deep down in the brainstem in some of the most primitive parts of our brains. Even though I say this is a recent study, you need to know that this reference that I just gave you is over 15 years old. But when you look at the other research that has been around that we use for diagnostic criteria and for treating our clients, a lot of that stuff goes back 70 years. So I guess 15 years is a little bit more recent. But the stuff that goes on inside your head, we do find by using PET scans, actually taking pictures of an active migraine, that there are persistent activations of the brainstem deep in the brain even after abortive treatment. Now that's kind of odd. You'd think that if indeed the problem occurs in the brainstem, if we're successful in our treating, that the brainstem would go, whew. No, there's still some persistent activation going on, and it has to do with some neurochemicals. When we start hearing about neurochemicals, a lot of folks go, oh my God, this is so confusing. It doesn't have to be. You've all heard of serotonin and Prozac, okay? Well, there are other neurotransmitters that may be involved, and one of those is called glutamate. It's an excitatory neurotransmitter. It makes indeed the brain kick in. Things happen whenever you're having glutamate being involved. And it is a neurotransmitter. Now, this suggests that the brain is in a hyperexcitable state during an attack of migraine. It's like everything's turned on, and that's why the title of this presentation was Brainstorms. Okay? Understand that there's a subtype of migraine with aura and that is caused by some other things going on. It could be either increased excitatory substances like glutamate or even some of the pathways that normally are there that would inhibit the migraine. They seem to be slowing down. Now, this does sound like it's getting a lot more confusing. I know that. But see, that's the point, because migraines are also confusing. Okay? But I did want you to know that what we're looking at is that there are chemicals in the brain that appear to cause inflammation, and when you have these inflamed nerves, you add to that the concept of the blood vessels getting larger. Now, why is that important for migraines? Well, the big thing is that, well, if we could then decrease the blood vessel size, we could treat the migraines. If we could relieve the inflammation, we could go ahead and treat the migraines. So you're already getting into the idea about the pathophysiology. Here's what's wrong with the body. How do we fix it? We either block it or increase the activity of what's going on in the brain. All right? This is going to make sense. It really will as we move forward. But that rather intensive description of the cause of a migraine, bigger blood vessels, and inflammation, okay, actually explains why certain medications are used to try to treat migraine. Now, this should make a whole bunch of sense. Let me give an example about an inflammation, and that's if you take a hammer and you smack your thumb. What's the first thing you do? Come on, everybody does it. Well, maybe the second thing. First thing you may go is ow or swear, but everybody grabs their thumb in an effort to stop the swelling, in an effort to stop the inflammation. Does it work? Well, I wish I could say it does. But the idea is, you think if I stop this, it's going to handle the pain. But it's hard to go ahead and grab your brain when it's inflamed. And that's where we can really run into the problem. However, we can stabilize the blood vessels and some of these inflammatory chemicals by using pharmacology, by using aromatherapy, by using just a whole bunch of different things that we wanted to go ahead and show you. This is actually the end of about 10 minutes worth of my presentation. I just wanted to go ahead and give you an idea of what it's like to hear Tom Smith give a presentation. Thanks.